Hello, everybody. Thank you for joining us this afternoon. It's 12 o'clock, so I think we're going to get started to allow Kim the most time that she has to speak with us today. It is my great pleasure to introduce to you today's presenter. Kim Bennion has worked as a registered respiratory therapist for over 47 years in adult, pediatric, and newborn intensive care, and has a certified healthcare senior compliance consultant for 14 years. She is currently leading Intermountain Health's respiratory care clinical research studies, has co-authored a recently submitted manuscript, and is leading a study utilizing remote patient monitoring on an AI platform for adult patients with chronic obstructive pulmonary disease and asthma. Kim has authored and co-authored over 80 abstract publications. She was awarded the 2014 Charles W. Serby COPD Research Fellowship by the American Respiratory Care Foundation and was awarded the American Association of Respiratory Care's 2018 Specialty Practitioner of the Year. Kim was heavily involved in the passing of the Utah's 2018 SCR 004, which raised the awareness of the need for postoperative home monitoring of high-risk patients receiving opioids for pain. She is currently serving as the Utah Division of Professional Licensing Board Chair and recently completed her roles on the AARC's Board of Directors and as the Chair of the Leadership and Management Section. Kim continues to serve on several strategic planning committees for the AARC and was named a Fellow of the American Association for Respiratory Care in 2022. I was fortunate to attend Kim's inspiring talk at the AARC Congress in Nashville, Tennessee in November 2023. I hope her message today leaves you as inspired as it left me. Welcome, Kim.
Thank you so much, Corey. We'll just jump right in. It looks like I have a lot of slides, but we'll click through them pretty quickly. What I want you to know is this is not a brag session. It's a really how-to session, and that's what I'm hoping you'll extract from it, especially speaking directly to students. I remember when I entered the field, I wanted to make a difference, and that was my main goal. And I didn't realize how long it would take for me to be able to achieve some of those goals I wanted. I want you to know I have no conflict of interest. If I mention any products, I'll explain why we selected these products. It's not an endorsement in any way, because I'm in the middle of the study to see if they really will have any effectiveness in helping monitor patients. I can't endorse them yet at all. I am a member of all these different organizations, but there should be no conflict of interest in any of those. I wanted to talk a little bit about our learner objectives. I think what I want to share is COPD dashboards and predictive scoring as we use them with our electronic medical record tools. And the main goal that we started with, that we're kind of shifting from now, was just to decrease 30-day hospital readmission rates. The Centers for Medicare and Medicaid, you'll hear me refer to it as CMS, is the largest insurer in America. And that's predominantly retired folks and those that are disabled, so Medicare and Medicaid. And they began in 2014 charging us, really dinging us, I guess, reimbursement-wise, if patients were discharged and then readmitted or died within 30 days. And the assumption was we just hadn't taken care of them adequately enough to keep them out of the hospital. So fair enough. The other thing that we're going to really look at is this comprehensive approach to COPD management. To my knowledge, there's nothing like what we've helped create over the last 2 years and implemented in March that's really doing the things that I feel we're trying to do anyway. We're going to talk about COPD, or chronic obstructive pulmonary disease care plans, using a care dashboard that our pulmonary disease navigators utilize to really provide high-touch personalized care. We're going to hopefully be able to earlier identify exacerbation, so patients' breathing is worsening, so that we can intervene in a more timely fashion. And then I'm going to end at the end of it to fill you in on some real detailed parts of our remote patient monitoring and artificial intelligence to be able to scale what we've been doing manually. So you have to understand, I think, a little bit about our governance within my organization. I'm going to explain to you some of how we identified the clinical problems and performance, talk a little bit about the care redesign and the alerting that we have. show you how we set and monitor our key process indicators, saying, are we moving in the right direction at all with these patients, and the dashboards we've used and are using. I just want you to see kind of an implementation timeline and the outcomes, and then the outcome synopsis. And that's really sounds really comprehensive and maybe boring, but let me get into it so you can understand exactly what was happening at the time this all started. In terms of an organizational overview for Intermountain Health, we've had a recent merger with SCL. And so right now, with the merger, we cover 7 states. You can see those. We have 33 hospitals and 1 virtual hospital. We have 4,800 licensed beds, 66,000 caregivers. We have a $15.7 billion total revenue. We have our own insurance arm, which is Select Health. And then we own and operate 385 clinics. So we're a large footprint. And when you look at it in a map, you can see just how integrated that is. So in the Intermountain West, we are broken up into 3 regions: the desert regions, canyons, and peaks region. And I just wanted you to see that map so you can understand this has been no small task from where we've come and where we are. But I want you to know that I really believe and espouse this mission, that we are going to help people live the healthiest lives possible. And we can't do that with reactive medicine, which is something that we've had for so long, right? We wait for them to get sick, and then we jump in and we're going to get them all better, kick them out the door, and then they get sick again. So that's been my motivation from the get-go, is to help us get to really value-based care. So whenever you're speaking, and this is, remember, the how-to, whenever you're speaking to senior leaders or accountants, you've got to really speak their language. So I took this governance and accountability for the leadership model, and I kind of threw it back in their faces a little bit. I said, do you believe we empower each other? Because I need to be empowered with some financial backing so I can do the thing that we want to do. And I started this mantra in 2011. I said, if we're mission obsessed and we really are looking to inspire and promote and focus on our patients, we need to help them be part of their healthcare team, right? And not just tell them what we think they need, but listen to them, what they say they need. And then we want to be driven by results, right? We want to prioritize and work together and improve, and then act with courage. I said, please, I kept saying, please help me act with courage. I want to shape the future. I'll own the message. If it doesn't work, I'll take the blame. I'll take the fall. But I really want to lead with a growth mindset, and I need you to help me, empower me to do that. Well, saying that doesn't mean anything, but showing them what you can do, it really does speak volumes. We have a community health report that used to come out quarterly and then annually, and there were 3 kind of social determinants. We want to understand and address patient needs. We wanted to prioritize our work and measure our outcomes. And here's the most important one for me. I wanted to improve access for our underrepresented community members. And when you think of those, think of predominantly self-paid, uninsured. Well, way back in the 90s, we created care process models, and this was created with teams of physicians, often other clinical workers like registered respiratory therapists. And it was kind of I wanted you to see the overview because it's like a step through, if this, then that, yes, no, and then it takes you down in a very easy way that you can look at where do I need to go next, and kind of helps guide standard of care. And this was based on the World Health Organization's gold standards for COPD. So this was based on that. So let me mention a little bit about how digital technology services really supports us in our organization, and you need to know some of the history. I told you we merged with SCL that was founded in 1972. Intermountain was founded in 1975. You see 1983, we have our Select Health insurance arms, which helps us kind of get our hands around total cost of care or cost per patient per month. We implemented medical groups where we now had employed physicians. We had clinical support services, of which respiratory supports all of them. Think of it like pediatric services, child health, CV services, et cetera. And then Civica, you see on the right, is our attempt at decreasing the cost of producing high-cost medications like some of our chemotherapy drugs, et cetera. And then we merged, and we now have this new brand. So we've had a lot of changes going on. And to be able, I say that because man, to continue to be able to be something meaningful and bring something meaningful to an organization who has changed so much and is expecting so much, you really have to step to the plate, especially as students or research scientists. This is our digital footprint. So you can see in almost every state, we have somebody working for us remotely to help us with our digital platforms. And for that, I'm really grateful. Without it, we would not be able to do what I'm going to share with you in just a bit. Everyone, this is our mantra, everyone with a stake in healthcare plays an important role. Intermountain, we strive to improve quality of life through our quest for better care and better health at a more affordable cost. One of our past presidents, Barack Obama, had stated and actually pointed out Intermountain Health as a model healthcare system. And boy, when that came out to be, I thought, well, we better make sure we are. We can't just say we offer extraordinary care. We need to show that we do and share that. Our journey starts really uniquely. This beautiful woman is my mother. I never see her picture that I don't remind myself that that's why I'm in the field. My mother had smoked in the 1940s during the war, before the Surgeon General warning in the US came out in 1964. When she found out that cigarette smoking was hazardous to your health, she quit cold turkey. But she was one of the first patients that we piloted this program on. And this is what she said shortly before she died. She said, I lived to be 88 years old because of this program and my respiratory therapist. I thank them with every fiber of my being. In my eyes, RTs are the rock stars. And I love that. I love that. And I shared that with our leadership. I wanted them to know that, this patient anyway, believed in us. And I'll share two bookends. My mother had advanced degrees, was very educated, wasn't wealthy by any means, but had plenty of money to be able to access healthcare. And on the other bookend that you'll see, I'll introduce you to somebody who did not. So first we had to define, was there a clinical problem or problems, and how were we performing? So early on in 2011 and 2012, before I had a data analyst and before I had all these resources at my fingertips for research, I just had to manually pull data and dig through records. And I used RT students as interns to help me. We dug out looking at about 26 key measures. And there we found where we had some areas for potential process improvement. We support 9 clinical programs, and some of those we needed their help with getting this big lift done. We really wanted to test 4 key factors. We wanted to identify areas of improvement. We wanted to identify key stakeholders that we would need to partner with to close gaps. We wanted to expand healthcare access and provide more timely care with the implementation of pulmonary disease navigators. You'll hear me call them PDNs, and they are advanced respiratory therapists who are registered, who work both in our hospitals and our outpatient setting in what we call the ROC, or respiratory outpatient clinic. And they help patients navigate trying to offer them a place for care outside being admitted to the hospital or in the emergency department where care is so expensive. And the fourth was really to improve our reporting metrics for our executive leaders so that we can continue to get the support that we needed. And we really wanted to test that hypothesis. If we could find the right patients and care for them in the right location at the right time and in the right setting, most often their home, which is less expensive, could we decrease 30-day readmissions and mortality and improve overall care? And that was really our goal, and it's been our mantra since 2011. We took our outcomes and we dumped them into what we created to be our COPD playbook, which I will share with anybody. And that became how we kind of ticked and marked off whether we were really advancing. And I'm going to show you some screenshots of that. And then, of course, even though it wasn't beautiful, even though it wasn't the best news, we actually reported in an abstract format to the American Association of Respiratory Care in their Respiratory Care Journal where we were falling short and what our goals were improvement. And it's for that our team received an award. So I wanted to show you kind of what the pieces of that abstract look like. And first, I'll start with this up here. When we talk about comorbid conditions, I wasn't surprised that, when people smoke, they have heart disease, they have lung disease. I wasn't surprised that if they couldn't breathe, they were anxious and depressed. obstructive sleep apnea, there's an overlap syndrome with COPD. Diabetes is common. Strokes are common when you smoke, and renal failure. That didn't surprise me. What surprised me is the chronic pain. And I didn't understand that until in 2014, the Surgeon General's report of the impact of tobacco use in America for 50 years, denoted that it started, so the Surgeon General's label started in 1964, smoking may be hazardous to your health, could cause heart or lung disease. Well, there were 29 directly associated comorbid conditions in the 2014 report, one of which was all kinds of associated rheumatoid arthritis. And that's when my brain went, oh, okay, I get it. It's chronic pain from the arthritis, because lungs don't hurt like that. And so that became, oh, if we read everything that we can kind of connect the dots. The other thing I wanted to look at and was found really interesting was this general, what compliance or non-compliance. Sometimes, these patients are high risk because they are lower education, they've smoked, they are not always literate, etc. Well, we thought we had this phenomenal education program for patients, but we found that, look across that line, that whole line right there, and at 60% were still using tobacco, 22% had medication non-compliance. When we dug into it deeper, we found that they couldn't afford it. If one inhaled medication is $500 and you've written prescriptions for 3 and it's $1,500 a month, remember I told you these are some of our most indigent poor, many of them. So how in the world could we expect them to take medications they can't afford when it really came down to food or housing? We had to find medication that was affordable. And so to me, they weren't non-compliant because they didn't want to be. It's the same with clinic appointments there. They weren't keeping their clinical appointments. They were canceling the day of. Well, if you're really short of breath and you're on tanked oxygen and you have to load 6 cylinders into your car, by the time you got them loaded, you're too tired to drive to the hospital or to the clinic to get care. So those were kind of some of the secrets that we found. And sadly, we found very few, though they had advanced care planning instructions, very few had opted or even knew that they could be taken care of at home when it came time for them to die. So those we saw as real good avenues that we might improve. We published everything that we could. And the reason we did this over the years was we wanted to keep our executive leadership team, you'll hear me call them ELT, we wanted to keep them engaged. We wanted them to know that we weren't giving up, that we were continuing to march through to help these patients. And we discovered many, many awesome things along the way. This is a picture on the left of the actual COPD playbook, what we call the executive roll-up. It's a very large book with details of what we were going to do, but we wanted them to have a synopsis. So you can see we would do red, yellow, or green as we were in progress. We identified the issue. We'd keep them apprised at that time, doing quarterly updates, and then let them know when it had closed and who had closed it. I blew this up on the right-hand side so you can see it. Things so obvious. We needed a COPD, a chronic lung champion physician, and we didn't even have that. We wanted to create the exacerbation protocol that the RTs could use based on that care process model I shared with you earlier. So they would have a standard of care, best practice. We wanted to monitor the protocol utilization. If physicians weren't ordering it, then were we not marketing it well? Did they not understand it, or did they disagree that it was best practice? We needed to know those things. Pulmonary function testing is the definitive way to both diagnose chronic lung disease and also to be able to stage them. The government doesn't pay, anyway, in the US, doesn't always pay for mild COPD. They should, because we should get on it earlier, but they pay for like pulmonary rehab if you're moderate, severely, or very severely diseased. We created the COPD playbook and presented it formally in 2015. And then we began our full pulmonary disease navigator pilot at one facility in 2016. You can kind of see we wanted timely referrals to pulmonary rehab, pulmonary function, dietary, sleep. Obstructive sleep apnea is a crossover disorder that's often associated with COPD. So we needed to identify those earlier, because if you go anoxic, at night, you're burning brain cells and other cells for vital organs. We wanted to know, could we fairly say when you would be expected to die within a year or two with COPD? And it's not an easy thing, and there's not a lot of literature out there because it's a waxing and waning disease that can go on for years. It's not like some lung cancers where you're diagnosed and gone in 9 months, very predictive. That's not the true with COPD or even with asthma. Advanced care planning, we wanted to make sure that we as pulmonary disease navigators could help the physicians be extended. We had gotten some funding to be able to lead these discussions and kind of shore up where we weren't offering best practice and getting advanced directives and honoring them. So we wanted to make sure that we could do that in a best practice way. And Gunderson Health has a program called Respecting Choices that we went and took the course in Wisconsin. And we were selected as our COPD patients were selected as the first pilot within our organization to go live with this kind of discussion. It was so worth my while to get to really know these patients personally. Then we wanted to make sure they had a discharge plan. We'd been kind of filling out discharge plans manually. We wanted those PDNs in the RRT clinic to be able to really improve healthcare access in a cheaper setting. We wanted to make sure that we could give the patient something in writing about their COPD and how to follow up and to whom they might come to follow up. Again, the verifying and honoring advanced directives, we wanted to more accurately report our 30-day readmissions. We wanted to employ registered respiratory therapists at our telecritical care desk. We had asked for 3 years with a business plan, and it was like, well, we're not sure that would be, no. Well, then COVID hit, and guess what? We had been ready for 3 years. So within 2 weeks, my partner, Carrie Winberg, had people hired and in those seats. And they've had over, I think, 24,000 saves, I believe. And what it is the eye in the sky, right? It's a registered respiratory therapist that also generally was on our life flight, our air medical team. And they would radio in, I say telepathic, it was telecritical care at its best. They would log into the room and be able to be that second set of eyes. And during COVID, it was a godsend. When that ended, we had been so affected that the physicians were the ones that went and said, you cannot take our respiratory therapists from that telecritical care desk. They were the eye in the sky to help the boots on the ground folks where we were short staffed. So that was a great thing. And now they'll have oversight for the respiratory outpatient clinic patients that will be on these artificial intelligence platform at using these devices. They'll be our after hours care. And then in 2021 and 2022, we took that data and mimicked what we had done 10 years before and are happy to report that we closed so many gaps. There were others still out there fledgling that we're working on now, but we had closed many gaps. I say publish everything that you can, students. Publish everything that you can. Our executive leadership asked us to present a poster at the Leadership Summit, and we were awarded first place. And when you do that, they start believing that maybe you have a good idea and they might just fund it. I'm going to blow this up a little bit so you can see. What you'll see is that first column where it says implementation. So that was our hospital at readmission rates for COPD was 16.67 per month, okay, per month at one facility. We implemented the PDN, the Pulmonary Disease Navigator program, and you can see that within 2 quarters, we were down to 11.5. Then the next year at the same time, 8.2, and then the 4th quarter, 3.45. Whoa, and that's a lot of money to be captured, and I'll show you how we captured that. So how did we redesign and set up alerting? I'm going to clip through this really quickly. We just said we need screens. We need meaningful screens, not just generic screens like you sometimes see with an Epic or Cerner product itself. So we created screens, and this was easy documentation for the PDN. You can see they can just click through, but it also made it, now I can query and I don't have to hand extract data, right? I can, if you look, we now have COPD and asthma exacerbation protocols for our outpatient settings for our pulmonary disease navigators to use. And again, how many times have they been admitted in the last year? How many visits to ED or Instacare? We can at a glance see who our quote frequent flyers or frequent utilizers must be. And then this is that obstructive sleep apnea questionnaire. We use Stop Bang and the Epworth sleepiness scale to risk these. And you can see up on the right-hand side, how we identify them as high risk, low risk, or no risk. And then we get them referred to their sleep study so that they can be put either on an oral device or wear oxygen at night and or a possible CPAP machine, a ventilator at home. Again, how we take the cardiac and pulmonary history, very detailed. We wanted to look at the touch points where we had used information technology in our EMR. This is kind of our workflow process for the PDNs. Down that left side is how we get referrals. In the next is clinical coordination. How do we coordinate with the primary care providers that are sending their patients to us? What kind of physician supervision in the third column do we have for our pulmonary disease navigators? And then what kind of care coordination? And you can see there's what, 7 touch points of where now this EMR information technology solution has come into play. I'm sorry, if you're talking, do you mind muting your phone? I'm getting feedback and I just don't know if it's me or if you have a question, but we will have chance for questions at the end. Thank you. This is a risk stratification score. It's you can look across it. It's patient. It tells you what they have, what their admitting diagnosis is, and lets us know if they've smoked. And there's a score, and I'm going to show you. It was externally and internally validated. We get this report every day, and we can look across, identify who has COPD, where are they at risk, low, medium, or high for death in a year or death in 30 days, trying to do that prognostication criteria that I talked to you about earlier. This is what it looks like, kind of blown up. It's a single blood draw, and we're looking at hemoglobin, potassium, creatinine, albumin, their chloride, and then it stratifies them. High risk is if they're ranked to number 1, lower risk if they're ranked to number 5. And I will tell you that using this, I could easily see that my mother was towards end stage, well before we normally would have been able to do that. And this has been validated at National VA data and University of Chicago. This is our protocol, and I've doubled it. So you've got 4 pages. This is page 1 and then page 2 on the right. But let's look at page 1. We historically, and this is important to know so you can see how we got to this research that we're doing now, we would historically ask the patient, are you coughing, producing mucus, or short of breath, the worst, same, or better than you were yesterday, or 3 days ago, etc. And then we would stratify the patient over on the right-hand side. If you look at that column, how were your symptoms? We would rank symptoms mild, moderate, severe, or imminent arrest, which then they would go to the ER, the emergency room. And then we would look at functional assessments. What's the sputum volume? What are their ADLs, their activities of daily living? Can they take care of themselves? On this, I want to show you where the arrows are on that first page. Where you see the caduceus, that's where we would stop. If we were having to step up therapy to keep them out of the hospital, let's say put them on CPAP, or at the time, depending on what we were doing, we would notify the physician or the advanced practice provider, who's a PA or a nurse practitioner, and let them know. We would recircle the loop and redefine the care plan and then implement it upon order from the physician. Then the last 2 pages on the left-hand side, it really dumps them into a bucket. Are they mild, moderate, or very severe? Very severe is, again, or a pending arrest is going to go to the ER. But we could implement therapy without having to talk to the physician. We would be able to start their therapy, et cetera, and move them through the treatment plan. I've kind of blown it up over here in the middle. And then on the right, we would manually ask the patients when they came into the hospital, or ask them over the phone, to score themselves this MMRC dyspnea scale or this COPD CAT scale or COPD assessment test, our way of trying to be a little bit more objective, but still very manual. And then finally, we really needed to have a PFT. Pulmonary function testing is, again, the diagnostic and the severity. So what we would do is, if they hadn't had one that was a diagnostic, like maybe they'd been tagged with COPD in the ER because of their smoking history and barrel chest, but they've never been tested, so we couldn't stage them and say, how severe are they? Because remember, the goal was also to be able to say, what's the prognostication criteria for their survival in a year or two? And we determined they had to have a baseline PFT, and then wherever they started, and then every 2 years after that. And that helped us then know when we could refer them to whatever they needed. So here's our key process indicators and dashboard. You've seen this before. This is where we implemented the PDNs right there. But if you look down at this bottom scale, you can see this was 2016 Q2 is in blue, and 2017 Q2 is in blue. That's comparing year to year. And then Q4 2016 and Q4 of 2017 really showed the impact of a pulmonary disease navigator and that high-touch personalized care. We did a study. We received $10,000 from our research grant. That was our first big money, right? And we manually took a pulse oximeter and looked at their oxygen saturations. The in-check dial is a dial that measures your inspiratory flow to see if you could overcome the resistance of a dry powdered inhaler, because often they couldn't. We found that 19 to 24% couldn't in 2 studies that we did. And then we used this thing called the MIR Smart One, which is an expiratory flow device. And for those of you not familiar with lung disease, chronic lung disease, COPD, asthma, those are obstructive diseases. If you've got mucus in the airway and swelling in the airway, you're not going to be able to blow out the same amount of air as per however many seconds that we're measuring it, that somebody with a healthy airway. So we wanted to know how much obstruction they had. And what we found with this study, sending them home, manually collecting the data on Mondays and on Thursdays, 53 patients entered this study. Only one was admitted during the 6 months that we ran the study, and she was not admitted for COPD. So that was something. And then we found that we would see this FEV1 drop. If you look up there in that left corner, you can see that drop. That would drop 10%. And we would note that they were desaturating and exacerbating. In other words, they were getting more short of breath, coughing more, etc., 3 days before the patient reported it. So we knew we were onto something. And then because we really wanted to say thank you for the funding, here's what we did with $10,000, you guys. We saved $800,000 in cost. And so that spoke volume now to the other group, the financial folks. Was it worth our time to do this? And we say it absolutely was. However, handling more than 50 patients a month in this manual process wasn't sustainable. So I'm going to share with you how the eye care study came to be. These are just some more metrics that we looked at. What's really important is you look at are people using the protocols we developed. And you can see during COVID, everything went kind of into the toilet, didn't it? But as soon as COVID was over and we re-educated, we were back up with utilization of the protocol. Again, wanting to know why physicians weren't using it. Were they not aware of it? Did they not like it? Did we need to get feedback, et cetera? Because it helped us to have standardized orders that the RT could act on and step up or step down without having to contact the physician every time, unless they hit one of those caduceus that we talked about earlier. Again, we wanted to know, how were we doing with telephone follow-up visits? Remember, this was a very, very labor-intensive manual process. So I wanted to make sure that they weren't getting overwhelmed with phone calls. Here was the test in the pudding. So during COVID, you can see these 2 facilities went up. So IMED and McKay-D with their hospital readmissions. Well, we wanted to know why, and so did our executive leaders. Well, at IMED, they provide the highest level of care, and they have all the COVID long haulers. But what was really important was that the PDNs were pulled to work in the units during the pandemic. So these patients were no longer getting this personalized care with the human. And that same thing happened with a few other variables at McKay-D, if you look. They lost their pulmonologist, he retired. They had a respiratory care leadership change, and then they too pulled their pulmonary disease navigators to work in the units. And for me, this was the point that I needed to make. Are PDNs valuable? If you looked only at hospital readmissions, you'd say yes, but now you can see what happens when you pull them away. So that became a real good sell for why we needed PDNs and we needed more of them. And we are now in negotiation of putting pulmonary disease navigators in physician clinics. So that's pretty cool. So what was our implementation timeline? This is very busy. All I want you to look at is that red mark, that red line that's going across. That's the CMS penalty line. If we go above that, we lose money or we pay money. And then what I want you to look at is the blue line. That blue line that's going down, that's the actual Intermountain COPD readmission rates. And look how low they are now in 2022. You know, that was the last time I pulled the data because we applied for an award. And you can see from the implementation of all these strategies all the way down, look at that. So that shows sustainability. So they know, our executive leaders, that what they're investing in, they're getting a bang for a buck. So what's the synopsis of all this then? So between 2017 and 2022, all-cause 30-day readmission rates decreased from 18.2 to 7.1%, and you don't need to be a statistician to know that was statistically significant. That we found in 2 different studies that 19 to 24% of patients could not trigger the medication device. Well, if you're using these really expensive medications and they can't even trigger it because they have no inspiratory flow, something's wrong, right? You're not treating them appropriately. So we would switch it to either what we call a soft mist inhaler or a nebulizer. We enhanced the coordination of the patient's care among all the clinicians. Now it's visible in the electronic medical record and they can see it, but it also made it so that we could print it for the patient. We improved healthcare access and timely communication of patient because we allowed the therapist to author for the physician. So where you saw those caduceus, within our EMR, they could author for, they would write the order and then send it back to the provider who would authenticate it, and then we would implement it without ever having to have 50 million phone calls. That really saved time. We improved compliance to federal regulations. Federal regulations are in America are very strict on when you can use protocol, standing orders, and order sets, and who can use them, and under what clinical conditions, and were they developed with best practice. So we were able to really improve compliance with that. Again, only that one patient was readmitted at our one hospital during COVID pandemic. And then the NCQA grant, we received $50,000 to have these be part of an investigative 8-hospital team that had really meaningful discussions with their patients. And I'll introduce you to one of those patients here in just a sec. So what did we learn? Well, starting off, selling the PDNs in that respiratory outpatient clinic as an optional site of care was kind of challenging. People were like, no, let's just have them go to the ER and, but we were able to win trust and show that we were reliable in referring the right patients to the emergency room. We had routine reporting proved really important for us to have engagement and goal achievement, both within our team and within our executive leadership. We had evidence-based protocol embedded in the EMR, our electronic medical record, really enhanced workflow. The therapist could hover over it, the doctors could hover over it, and see exactly how that protocol was going to be implemented. We had a sharing and celebrated success all along the way with our PDNs, our other therapists that were sending referrals, and all those groups of executive leadership team. Really, it helped us stay actively engaged. And we were able to show that patients cared for in the respiratory outpatient clinic, that it was another low-cost effective site for healthcare access. And then we improved healthcare access. In doing so, we do provide the right care to the right patient at the right time at a lower cost. So how will we scope and sustain it? So I told you it wasn't, right now, our pulmonary disease navigators, if they were to only use the manual process, could really only see effectively about 50 patients a month. Now we're able to care for about 250 per month. So, and this is how we're doing it. We call it the eye care study. It's intermountain COPD and adult asthma remote evaluation study, and this is what it involves. So it's remote patient monitoring on an artificial intelligence platform, meaning that I'll use CareCentra is the artificial intelligence platform, and it's loaded onto their phone. Okay, they can opt in or opt out of this study. It's loaded on their phone, and all of these devices that do the physiologic monitoring Bluetooth to the patient's phone and to the platform. We're doing a step wedge cluster study that just started March 18th, meaning that we have a hospital that comes online for 2 months, then they continue, and the next hospital comes on for 2 months, and then the next hospital for 2 months. And when by November of this year, we'll have 5 hospitals with pulmonary disease, our major medical centers with pulmonary disease navigators, then running this study through March of 2026. We're comparing the standard of care. So those patients that opt out and say, I don't have a smartphone, I don't want to do it, I won't do it. So we're still doing manual care because that's going to be our control group, right? And then we'll have our AI, artificial intelligence, remote patient monitoring digital journey that will be loaded on the patient's phones for those that want to opt in. We have EMR integration for COPD and adult patients. So we'll be able to see this as part of their record. We'll utilize 4 Bluetooth devices, and I want to show you those. And this kind of builds on that original study that we did. Number 1, we're using a pulse oximeter. And I'm not endorsing or not endorsing. I'm just telling you, I picked this one because it gives me the saturation, the heart rate, the respiratory rate off the pleth. And the FDA in America right now, in the United States, the FDA has only approved this one to extract that respiratory rate, though they've been doing it in Europe for a couple of years. It also gives me a perfusion index. So I wanted all those things on this device, because you can't say to a respiratory to a COPD patient, well, take your respiratory rate. What they do is they slow down and you don't get an accurate one. Then we use the MIR Smart One. This is an expiratory flow device. The patient blows into this with a mouthpiece, and it will light up on their phone, show them if they gave good effort. They do 3 blows twice a week, and we're watching that. That's that FEV1. So if they have inflammation, swelling, mucus, etc., it's going to be lower. And when it drops 10% or lower, that's when it will cue us on our platform. They show red. Something's wrong. You need to get a hold of them. So the next is it's Adherium. It's jackets that hook on to the inhaler. It will tell you the date and the time the patient shook it and took it, how many seconds they shook for those that are not dry powdered inhalers. Tells us about that inspiratory flow. Remember, we found 19 to 24% didn't have adequate inspiratory flow. Now it's going to tattle on them, right? Bluetooth to the phone and to the platform. And I'm going to be able to, at my desk with my dashboard, look and see which patients light up green, yellow, or red. Green means they're great. Yellow means, ooh, something's not right. And red means, uh-oh, we're in trouble. You better get a hold of them first. Now helping the PDN stratify who they call first. And then this remote patient monitoring device looks like an iWatch. It records for 4 days, and it will record their respiratory rate, their heart rate, their saturation. And we're working with the company for this ODI. It's oxygen desaturation index. That's if your oxygen saturation drops 3 to 4%. And there's debate. So we're doing 3 and 4% for 10 seconds or longer. And so many ODIs per hour indicate that you might be highly suspect for obstructive sleep apnea. Now, these aren't the only devices. When I tell you how many data points, you're going to go, oh my word. But we have PHQ-9 score, which is the depression score. I want to know if they're depressed or suicidal, right? It asks those MMRC and that dyspnea score and the CAT score and the asthma control test. It will give us now those scores because it pushes them to the patient, and then we can see them. We don't have to manually do this with the patient. And there are so many more. Our air quality based on your zip code, the Utah Clean Air Act, Idaho Clean Air Act, we're synced in with that so we can tell them, air in your area, it's really, really, really dirty air. It would not be a time that you want to go outside and go walking. So it's just so much more than that even. And then coming soon is this cough diagnostic and therapeutic. I love this. When I went to the Congress, I had somebody approach me. I very much believe in cough libraries. If you've never heard of those, we all cough differently. One of the things that we were able in the 90s to diagnose when I was working at that time with pediatric medicine, with bronchiolitis patients, not all coughs sounded alike. And at a 73% accuracy rate, my quality care assessment team could tell you, is that really a bronchiolitis cough, or is there something else going on? And we found things like tracheal webs, and we would refer these patients to the ENT with 73% accurate. It became the grand prize, who's got the most accuracy in referring and finding something. Or vascular rings that wrap around a newborn's trachea and literally squeeze it off, narrow it off. So we found a number of those things. And so I very much believe in this diagnostic and therapeutic cough library. So this particular company that I can't mention because I'm under a non-disclosure agreement, but we're going to bring them onto the platform because in COVID times, their diagnostics, they could differentiate between a COVID cough versus a flu cough with like 2 standard deviations of accuracy. So we know they want to be, and we want to be, creating a therapeutic. So remember when we were asking the patients manually, are you coughing the same, better, or worse? We won't have to do that anymore. They're just going to cough into their phone, and it will help us with this therapeutic as we build this. How exciting is that, man? Non-invasive. Nobody wanted those swabs in their noses or to be suctioned. I didn't. So this might be, a big answer. We don't know. We're going to try it. So what does it really look like? Well, these digital journeys are really personalized. The artificial intelligence platform gets so smart so fast. Like if you say, I only respond to email, but all you're ever responding to is text messages, it learns to start texting you instead. And this is what we'll get. There'll be millions of individual journeys. Right now, we'll have 18,000 to 21,000 data points per person per month to look at. And that sounds overwhelming, but not when they're in a dashboard that compresses them all into subcategories so you can see where your patient's struggling. It will can provide 1,500 to 1,800 nudges and alerts. So maybe the patient hasn't picked up their medicine and they were supposed to pick it up on the first day of the month. It's now the 3rd day of the month. It starts asking you why. Can you not afford it? Can you not get a ride? Do you not want to? And so now we'll be able to say at a glance, oh, he can't get a ride. And I'm going to share with you something we're going to implement. And then we'll have AI learning at the end of this study and analysis that will equal 7,000 patient years of data. We'll understand better what makes them tick, why they aren't compliant, what do they want more of or less of. And already in the first week that we went live at the first facility, we had 3 patient saves. One patient had been, if you can believe this, to the hospital not 4 days before. Nobody found out. Nobody asked, do you have your medications at home? She did not. She had one medication and she was taking her controller medication 3 and 4 times a day, which is not going to bring her relief. She needed oral steroids. And the other patient was one that had a mycobacterium. Really is bronchiectasis, not COPD. So we were able to find those and would not have found them without this artificial intelligence platform. Zipline is the thing that we're excited about. It's a drone. It's being used. If you look, this was, I think my data was, the 5th of April. They had done this many deliveries. Now in Ghana and around Africa, that's blood for maternal medicine. So mothers died when they bleed to death. They couldn't get blood in time. Babies would too. So this is where they tried it. But I'm proud to say Utah up here, we're piloting it now in 2 of our cities. And this will be how we deliver patient medications, inhaled medications, when they can't get to it. How awesome is that, right? And then I'm sitting here in Arkansas. My son works for Walmart, and Walmart is trialing it within the Northwest Arkansas region where I'm sitting today, and flying these drones, and they will land it on your front porch. It's not like it's going to blow out into the middle. It's within an inch of where they say that you want it dropped. And how cool is that to bring medicine like this to a patient's doorstep when they're already so short of breath that they just don't feel like they can get out and safely drive? So the bottom line is the right patient getting the right treatment at the right time in the right location. It always follows that cost will fall if we're doing the right thing. I have never seen it fail in the 6 major projects I've done within my organization. We received the HIMSS Davies Award of Excellence. This is a international global award for our use of digital technology in helping patients. And when I look at the very infancy of where we started in 2011 and where we've come now, in the middle of it, I thought, oh, I'm just going to give up. I just don't feel like swimming upstream anymore. But we didn't give up. And I can say accolades and awards and funding and all this stuff, but what I really want you to know is what really matters. I told you I would share with you the big bookend from my mother, very educated, funded, etc., to Brian. Brian passed away a little over a year ago. I met him when we were doing our advanced care planning discussions. He'd been in the hospital. He was 38 years old at the time, and he had had 2 MIs, so 2 heart attacks. He had been homeless for 10 years, started smoking, using drugs and alcohol when he was 10, watched his father overdose, had a mother die young, and he basically was on the streets, unconnected from his family. When I first met him, we had gotten him in government housing, government-funded housing. What I didn't realize is there's no furniture there, no food, no nothing. So he had been there for about 2 days. When I sat down and met him for the first time, I put my arms around him like I always do. I'm such a mom. And he said, oh, please, please don't hug me. I stink. I haven't had a bath in a week. And his dog was just as ratty as he was. I tried to have a discussion with him, but he was not very trusting. It took me 3 days of 2-hour discussions to get him to trust me, to have him know that we cared about him. Went back to my office that first day. I told my group of leaders, I said, everybody needs to take a room. We need to buy a few things for every room in his little apartment. And we delivered it to his door. We weren't there. We let somebody else deliver it. And he was so touched. He was just crying. Now, remember, this guy did not have Medicaid. He didn't have Medicare, any insurance. He was in here with no job, inability to work, and we were able to work through that. He had no glasses. So when I took paper products and he would look at it, I thought, he can't read that. I said, do you need glasses? And he said, yeah, I haven't had glasses for 7 years. So Brian, I took last year, I took my granddaughter to the beach. We were down on the beach, several states away. He called me that afternoon before I was to come home, and he said, Mom, I really need you. I made sure that guy had Christmas presents and everything every year for the years I've known him. And he called me Mom, and I said, what's up, honey? He said, well, I haven't wanted to call you, but I went into an extended care facility about 10 days ago, shortly after you left. And he said, I think I'm dying, Mom. I said, I promise you, honey, I'm home in the morning. I'll go from the airport to your bedside. But he died during the night. The week before he passed, before I left, I asked him what he thought about the program. And this is what Brian said. This program changed my life. It is high touch, personalized, timely healthcare when it's needed most. I love my RTs, and I love this program. I can hardly see his face and read that because it was my last words with him. But that is the symbol of success, not $800,000, not being able to see 250 patients a month. What's really important is that it's a winner chicken dinner with patients who need it most. I'm so grateful that I was able to share this with you today. It's been a long, hard journey, but I wanted to share the how-to so you don't give up as you step out in your quest to improve patient care. And I'm going to leave my contact information. You just have to remind me where you heard me speak, and I will help in any way, any kind of healthcare innovation. And if you've got a good idea, please share it with me. Let's work together. So thank you very much for having me. And a few minutes we have left, I think, for questions.
Thank you so much, Kim. Your talk today was slightly different than the one I heard you present in Nashville. But it gives me shivers, and it's exciting, and it inspires me. And I just want to say thank you so much for all the hard work that you've done.
Thank you.
Does anyone have any questions for Kim? While people might be thinking of a question, I just have one, and it's like bringing it right back to the beginning. How did you get your physician champions? What was your first steps sort of for that?
Really, it was creating that COPD playbook. when they saw the COPD playbook, doing the baseline research and seeing the COPD playbook and having worked with me on some other projects, I said, I promise you, if you'll work with me, we're going to revolutionize the way we care for these patients. And anybody in the hospital will tell you, cardiac patients get lots of attention. Cancer patients get lots of attention. But chronic lung patients, they just don't get the same attention or funding. And so they were like, oh, okay. And I dreamed, it was kind of crazy. I didn't even know about the eye care study. I hadn't named the study yet, but I had said, what we need is eye care for lungs. That's what we really need. And it's odd to me that it all fell into place, that the eye care study, you know, something I hadn't even envisioned. Some of this technology didn't even exist. I just knew even if we could do it manually. And so I kind of won them over by continuing to show them what we could do. And now I've got physicians, if I ask them to do anything, they're just so willing to help with anything. So I think you make them a believer. Great question, Corey.
Anyone else? Any questions? I have another one. I'm sorry.
Okay.
Just in case, well, we have a couple more minutes, I think. The kind of the innovation, the products that you're using, do you know if they're all, I'm sure, maybe you don't know this, but maybe, are they all FDA approved in Canada, do you know, or?
I don't know about the FDA approved in America. We have really changed them. Like, we've been working for 2 years with these companies, asking for like the ODI, the oxygen desaturation index, to be embedded in that, and working with them with the calculations. And some of these things didn't do the things that they're doing now. The inspiratory flow, that was something that we requested of Ethereum, and they were such great partners. This is why I say sometimes people get kind of nasty with vendors. Listen to them. They may have something that's just close to what you want. And if you really work with them, I mean, Adherium, CareCentra, and Intermountain are funding this. It's now a $5 million study. So that just doesn't just happen. They want to get something too. So bench testing their devices and seeing if we can make them work and improving their devices. So that's really kind of how you do that, is becoming partners with your vendors too. And I'm not sure about Canadian approvals yet. I'm not sure. Sorry, I should have checked that out.
No,
I know
that's...
Massimo. I know Massimo's up there. I know Massimo's up there.
Yes.
So.
Yeah. The idea of using drones, wow, like great. Like, we have a large population of people up north who are far away from like, we always have to bring them down to Winnipeg to get health services. So that,
can you imagine if you could care for them remotely and deliver things to them? This is what rural Utah is pretty rural in some places, and that's same with Arkansas too, and many of the states that we cover. So that was our thing, is we can care for them and send them things. My gosh, that just puts it at their fingertips when they don't feel well enough to do it themselves. So I really like the fact that you're thinking of your rural patients as well. That's absolutely what's most optimal.
Anyone else? Any questions? I think we're almost at time.
Thank you so much, everybody. I really appreciate your attendance, and I hope that it sparks in you some real motivation to be innovative. Always ask why. Don't take just because we've always done it that way as a good answer, because it's never the right one.
I've learned from you also, Kim, that data, use it, pull as much
Right.
data as you can, right?
That's absolutely right. That outcomes are the measure, right? You can talk all you want, but proving it to people really becomes paramountly important when you're asking for something new.
Yeah. There's a lot of people saying thank you and appreciative of your presentation today too in the chat, if you want to.
Guys, thanks so much.
Thank you. Have a great day, everybody.
You too. Bye-bye.